Waving. Nice. All right, we're going to flip the panel and do the intro. We'll go from there, okay? Give us a second.
Good morning.
Good morning.
It's Megan Coylwright and an excellent panel. We're so excited for your case this morning. Why don't you guys get started, and then when we have a break, I'll introduce who's up here with us.
That's great. I want to introduce who's in the lab here. First, my partner in crime every Thursday and Friday, Dr. Bob Riley, superb cardiovascular surgeon. Dr. Jim Hermiller, no stranger to our cath lab. Jim, thanks for being here. We have Dr. Robert Burke. He's going to give you world-class echocardiographic imaging. There's no one better. We have Dr. Ed Garcia, cardiac anesthesiology. In the room, we have Jeremy. He's our x-ray tech. We have Tracy and Maddie, our nurses. And we have Jamaica, one of our travelers from the Philippines who's going to stay with us. We're delighted to have her with us as well. So we have a great case. I want to jump right in because we have two cases. And then once we give you a little intro, Megan, if you can just introduce the panel. Why don't you go to our slides? This is an 82-year-old who had a mitral valve replacement about 6 years ago. I always tend to put the model number and serial number in my notes so that the next person that comes along doesn't have to guess. Degenerative bioprosthetic valve disease. We'll see a little bit more on that in a minute. Patient was referred to me, has both MR and MS in this bioprosthesis. Risk factors for coronary disease, though does not have coronary disease, has had atrial fibrillation, at least one TIA on that basis, and has had a permanent pacemaker placed in the past. Next slide. If you just go to the Valve and Valve app, you see the true ID, you see what the recommendations for the Valve and Valve app is great. It gives all kinds of nice recommendations on what to do. 29S3 is probably the choice. Herms?
Yeah, the only trouble is that pusher isn't back far enough.
Yeah, that's exactly right.
I love
all right,
that.
That's right from the Valve and Valve app. All right, next. Now, Bob Burke, we measured a neo-LVOT of 180 and change, obviously not sufficient, but the 5.3 millimeter distance, Bob, what do you do with that? Anything?
Again, that in and of itself is inadequate. You
Right.
really do need the CT data to get an area for the neo-LVOT and make sure that we know what we're going to be getting out of it.
If it's a centimeter, that's probably good, but
Absolutely.
Yeah, okay.
If it's huge, it's great. But when it's borderline like this, you really don't know, and you can't guarantee anything.
Herms, that neo-LVOT, when you and I first looked at this case, we had some heartburn about that neo-LVOT.
Yeah, that wasn't enough.
Okay, so next picture. You can see, I talked to several people who are part of this meeting. Carlos Sanchez, we talked to Adam about what we might do, and Adam and I talked about Lampoon, the new Sesame procedure, but we also talked about alcohol septal ablation. We have a pretty rich experience with ablating septa. Go to the next picture. And this patient had a beautiful septal perforator. Herms?
Yeah, this is beautiful. And you could just see on that CT, she had a big proximal knuckle in that
Right.
septum, right?
So Burke and I talked about this a little bit. Go to the next picture. And we contemplated doing as a first go-around, an alcohol septal ablation. And you can see the typical look to the right. After the alcohol is injected, you lose that septal perforator. That's a rather typical look. Next picture. And Burke gave me a target extraordinaire. When I put the balloon in the septal perforator, we put contrast in, and he showed that not only was the first septal perforator the only one that likely we had to ablate, but it showed perfectly the entirety of the knuckle.
Yeah.
So we knew we were in the right place, and we knew we only had to do the first septal perforator. Next picture. So now 3 weeks later, we repeated this CT scan. Herms, you and I reviewed this. Bob Riley, we reviewed this. Now the neo-LVOT is 233. Jim, what's your...
No, I think it's sufficient. That was just 3 weeks after, and we're even further down the road, and this thing remodels over 3 months. So, I think that's sufficient.
Now, there was a little bit of disagreement amongst some of the people we consulted. Paulo from Edwards said, green light, go, this is more than enough. Adam Greenbaum said, guys, I think you might still want to do a lampoon on this. Go to the next picture. Bob Riley, real quickly, talk to us about what the surgeon sees when you do these valve replacements.
Right, so this is just to give a surgeon's perspective of how things look here. This is the surgeon's view, obviously, with the anterior up top of the screen. And a couple things to point out here are, number one, with the mitral replacement, it's a chordal preservation procedure where all the cords are plicated to the annulus. In this one, right at A2, you can see the cut edge of the anterior leaflet where that portion, the belly portion of A2 is removed. Right under that label A2 is where the aortic valve is. So hopefully there's no LVOT obstruction from the bioprosthesis. Next slide.
I think this is one of the real benefits of the heart team, Bob. We have, the expertise of surgeons who are used to looking at these valves every day. Go to the next slide, please.
So it's the surgeon's job not to put the struts into the LVOT. So this is right before the valve is tied down. And the belly of the leaflet is where A2 and where the neo-LVOT would be. And the struts are over the trigones and posteriorly out of the way. So next slide, when you, this happens to be a double valve case. Next slide, please. When you're staring down the LVOT through the aortic valve that's removed, you can see the strut is out of the way and the belly of the leaflet is out of the way. You can imagine here that if you were to put a TAVR inside of this valve, it would expand no further than that strut and you'd still have an adequate neo-LVOT. So this is how we see it. This is how we try to obviate the need for any alcohol septal ablations or any problems in the future.
Next picture. Okay, so what did we gain? This is the repeat CT scan. You see the green arrow showing the thickness of that septum, and now we've gained all that. And I think that's going to be sufficient. Now, next slide. So our upfront strategy was alcohol septal ablation and reassess, and now we're going to go forward with the 29S3. Megan, real quickly, would love your opinion and the panel's opinion on this procedure.
What a great introduction, and thank you for setting us up with an awesome heart team on stage. We've got imaging expert Dee Dee Wang. We have interventional cardiologist myself. We have Ashish Prasad and Benita Shah and Srini Iyengar. And then we have some cardiac surgeons that are going to be ready to weigh in, very experienced, Kendra Grubb and Zane Copley. So I think we'll just open up the comment to Dee Dee Wang, given that we started with imaging. What are your thoughts about the new neo-LVOT after septal ablation?
That was one of the best live case presentations I've ever seen, so congratulations. I mean, having the surgical valve in there and just the back and forth, that's just amazing, and it's a pleasure to be here. Absolutely, that alcohol septal ablation was just beautiful. I've never seen anybody as excited for an alcohol septal ablation besides us at Henry Ford, so that was just wonderful. It was a sexy first septal perforator, and that was an amazing increase in the
Succulent first septal.
It was juicy,
Yeah.
and you guys did an amazing job. And there's a beautiful example of how echo can guide you with affinity contrast, and really looking forward to TMVR. The one thing I'll add, though, it's very interesting. Kendra, I'm going to bounce this to you. But one thing that I learned in the past 2 years is that surgical mitral valves aren't designed all the same. And the strut lengths are not all the same. And the surgeon showed us a beautiful picture of the surgical valve. But actually, not every single strut is labeled the same way. And sometimes they're labeled double slash for the lateral wall and single slash for the septal wall. But Medtronic, Abbott, and Edwards, they reverse how they label that. So you guys really have no standardization, and you're kind of left with no help.
Well, we do have the ability to visualize the annulus, but you're right. We're not necessarily basing it on a CT scan. We're not necessarily basing it on anything other than general gestalt of the echo that we see preoperatively. And so you're correct. There are valves with shorter struts, and there are valves with longer anterior segment, so that we have to position the valve in the operating room to try to stay out of the LVOT. Zane?
I certainly agree, but I do also echo the remarkable excitement about the septum being ablated. I mean, that certainly helps in this case. I think the millimeters of what you get in the LVOT with the valve profiles are important. It depends on what you choose. And to be honest with you, it's much of a muchness. So I agree with Kendra. We go with the echo. We try to make the right decision about the valve, and sometimes it's just about the pedigree of the valve and the heritage of our training with what we put in.
Bob Burke, was there anything else that you wanted to add to the overall presentation, what we did, how we proceeded, and our imaging? We got Dee Dee, who's an extraordinary imager. Is there anything else that you would add to how we made our decision to proceed like this?
No, I think the subsequent result on CT was really the most important thing, and we were expecting something to change, but we really didn't know objectively how much it would improve. The fact that the neo-LVOT area increased really 50 was great. I mean, that was really as much as we could have hoped for, and just anatomically it looks significantly better with now basically that involution and scar on that knuckle that's really cleared the way for us to be able to do this now.
I know Adam Greenbaum would lampoon this. Anybody else on the panel take exception to this and say, no, this is an absolute lampoon?
Ashish, Srini, can you guys comment?
So Dave, Srini here. To be devil's advocate though, why not have approached it with lampoon on table versus this, for the sake of that you would have had an unknown if you had done the myectomy, obviously, and not realized how much a gradient dropped. So was there any big mental push to do this procedure prior to just going lampoon?
Well,
Family.
yeah. We went back and forth on the lampoon. We went back and forth on the lampoon. And I will tell you that the family members researched this, and they were a little negative. And I even said, Google who Adam Greenbaum is. He's coming to do this with me. And there was a little bit of there was significant hesitancy to move forward with something like that. Now, that stated, I don't know why they would say yes to alcohol septal ablation and no to lampoon.
Well, I think there is one piece from just a hemodynamic standpoint that we do have to concern ourselves with, particularly with a live case. We know that we're going to be parked for a while with wires across and all that stuff. With lampoon, we create wide open mitral regurgitation that may or may not be tolerated well without mechanical circulatory support. That adds another degree of complexity for a live case and really was part of hesitation, when we had spoken before.
Yeah, and I will say, we've been struggling with hemodynamics this entire case, just having the wire across. It's amazing. It always works out. What do they say in Shakespeare in Love? It always works out, but it's a mystery. All of a sudden, we have normal or stable hemodynamics, but it's taken us a little bit with just that wire or pigtail across to stabilize this patient.
Well,
Yeah.
it's a beautiful discussion. It's one thing to add, since I have the Bovi guru and pioneer sitting at 12 o'clock in front of me, David,
Right.
with Adam Greenbaum here, that we have done lampoon, and they are hemodynamically stable when you go ahead and do the laceration. However, the one thing that's very interesting is fossa, the septum. I wonder if Burke can show us the fossa, and are there any possibilities that we might need to Bovi across the fossa today, since these mitral valve and valves typically have a septal closure by the surgeons on their way out?
There was no issue with the septum, and actually we can come back here. This is where we've crossed. We're at about 3.8 centimeters, and you can see that we went through. We did actually do a septostomy, which is what we typically do, but there was no additional surgical repair to the septum, so we didn't have to navigate that piece.
There's our septostomy. Can you guys see the still frame of the balloon there?
Yes, it looks good.
Did a septostomy, and then we flossed both the septum and the mitral valve without difficulty. I think we should proceed. What do you think, Herms and Bob Riley?
You got it.
Sure.
Okay.
While you're doing that, I just wanted to ask a question for the audience and for people. What is your minimum number of neo-LVOT that you'll be happy with? I'll pull wire a little bit, pull you off the greater curve there.
Come on, baby, get through that stuff up.
There we go.
Catching on the pacer
It's
wire.
taking the pacer wire up. Look at that, David.
Wire?
See that
So
pacer
for
wire?
Henry Ford, our neo-LVOT cutoff is 189. That's our published literature for our series across 5 centers. But when we have a valve and
See that
valve,
wire?
we know we
Wire
can actually
guys,
do a more
advanced
atrial
wire.
deployment and
Set
get more of a
wire.
There you go.
neo-LVOT. But that carries a
see if
risk
we
with the
can
skirt
get by
PVL
that
afterwards.
wire.
I didn't
Thank you.
think
I will
about
say
that.
for the audience, this piece is really important. This is a
Can
two-person
you
job.
give a hyperflex right there?
With
Yeah.
regards to the push and pull on the wire, and we can see
Let's just see.
there's just some bias against the lateral side of the valve, which is catching a
I
little
got
bit. So maybe we'll just listen into the teamwork here as we work
Yeah.
to get across the valve.
Yeah.
So Megan, what we're actually catching on is a pacer wire.
Look
if
at
you take
that.
a look, it's not really the valve itself. We're catching on the
I wonder
permanent
if I
pacer wire.
straighten it a little bit.
Straighten it a little bit. Try that.
Let's just see if this helps. Isn't that something? Now that's a new one.
So this is not an EP procedure lead extraction, so we're going to try and avoid that.
Try to turn the whole handle counterclockwise.
Yeah.
Let me
let me
see
do-
if I can. Yeah, go ahead. Let's see. No,
I'm
we got
turning
thing.
that.
Hey, Dave, this is a question from Dr. Reardon.
Yeah.
How big was the balloon septostomy? What did you use?
14. It was a 14.
Yeah, that's not our problem. Our problem right now is this pacer
The
lead.
ventricular lead.
I'm
Yeah,
just gonna-
no,
there,
it's taking it right in.
don't want to do that.
Isn't that? That is a new one.
And this is
Alright.
not a problem, unfortunately, when you're doing even something like mitral clip, finding that the atrial
Right.
lead is a swing almost that you're riding on top of, and it's extremely difficult once the transeptal's already been made to kind of maneuver around it.
Okay. Tell you what, let's do. Let's reset here. I don't know what we're going to do to get around this. Why don't we do this? Are they ready next door? Let's. I don't want to hold them up, but we're gonna reset. We're gonna recaucus on what we're going to do to get around this. And the minute we have a good answer, we're going to come back here. So why don't you guys run next door? They're going to do a Watchman device. And in the meantime, let's try and figure this out, shall we?
Yeah. What if we grab it with a pigtail or something? and try and-
Well, welcome everyone. Can you guys hear me?
We sure can. Thank you for being here. Do you want to introduce your team?
Absolutely. So, for those of you, I'm the relative newbie to SIF. I'm Rahul Doshi. I'm the pillar chief for complex arrhythmia services. So, hey, you have an electrophysiologist in the room. So, I apologize in advance. But we'll go ahead and go around the room to the entire team. We have my colleague here with me is no stranger to SIF, Dr. Alok Sharma, who's the co-director of structural at the Minnesota VA. And then you want to go around? Mallory, you want to start? We'll just go around the room.
My name's Mallory. I don't know if you can hear me. I'm a nurse here.
Right?
And we have Sunny on the tech, and Dr. Berg did the imaging for pre-procedure imaging for us. So.
Right, wonderful. So,
Raul and Alok,
Okay.
we have on the panel today Megan Coyle-Wright. I'm Steve Yakubov.
Perfect.
Kendra Grubb.
Is that it? No, go back one.
I think
Oh, never mind.
we probably still hear David.
That died.
We probably have to
Perfect.
cut the sound from David unless you want.
Okay, this is what we did. We just manipulated it and it went across.
When in doubt, push.
When in doubt, push and flex. Okay, you guys see it?
Show us what you did.
Okay, well, we're running it. Can you see Flora?
There it comes.
So this is a lot of clockwise torque on the system. Trying to put normally the E is down. Try to put it up to around 12 o'clock,
Boom.
and with the push and pull,
So
manipulate it off
this
that
is where
wire.
we're at right now. There's no tension on the pacemaker
You got
lead.
that, you got that.
And I'm maybe just a tad deeper. What do you guys think? Megan, what do you think?
You know what? We're going to have to get the pusher back.
Yeah, let's get the pusher back.
And that's going to, that always, you know, you never know what you're going to get.
When everyone does this case in the future, they'll hear Herm's voice. Get the pusher back. It looks like you're trying to the transcatheter stent struts with the ventricular valve struts, as Adam Greenbaum outlined earlier. So looks like you're starting in a good spot.
A little bit farther back. there,
Dave
huh?
and Jim, can you tell us about how you protect the LV apex when you go across the fossa? You know, commonly in valve and valve, we have that diving motion when you finally make it across. How do you prevent that apex from getting injured? What is your technique?
Pray, hope, don't push too hard. It's a great question, and we've obviously, over time we've had problems in the past doing that, but it's just being very cognizant of the wire, not over pushing on the wire. Anybody else have any thoughts that way? I mean, it's just being careful, I guess, to simplify it. All right, what do you think of our position there, Megan?
I like what we learned from Adam earlier with regards
I just
up the
unflexed it a
valve.
little bit.
We can
I
see
heard
that the
Kendra
distance
say
in the
that.
V is okay, but I think trying to get it coaxial is a good idea. Steve, what are your thoughts?
I agree with you. You know, do you have your flexion off right now?
Yeah, we do.
Okay. So I think you're trying to figure out where you're going to land this thing in the AP or in the intermedial and posterior lateral position. And Adam showed some great slides on the session before about orientation, what to expect on this. And Dave and Herms, it looks like you're way off. How's that?
David,
What's that?
Adam says you're way off of where he would do it.
Okay.
Yeah.
Thank you, Adam.
says that's how it always is.
All right, what do you think?
We've got.
Adam is making a few comments for
Here,
you
why
as
don't
soon
you-
as we can get the mic to work.
Get all that flexion off of it.
Let me try this. Let's see if this changes anything.
You're going to push it in? I push it in. Maybe it'll push it up. There you go. That ain't bad. How about that?
Okay,
Adam?
so what we talked about was a couple things you can do if you're stable.
Yeah.
So if you were to put a little bit of flex back on, and then rotate the delivery system clockwise so that it's posterior in the atrium, you'll see that the anterior posterior dimension will get better. You see that?
Uh-huh.
So it's actually.
You like that?
That's really good.
So that's better, right?
Yeah,
So
I
that's
like
how you
that.
fix the canting in the anterior posterior dimension. The Magna is also very good at helping align. Do you have any push on the wire right now, or zero?
Really,
Pretty neutral right now. There's push.
You know, the posts on that Magna help you in this case, in
Yeah.
contrast to the Mosaic case
Right.
that you showed earlier, Adam.
I like
so-
that, Adam. What do you think?
Yeah, I think that's better. You agree?
Yeah.
All right.
I
The
think
other
that's a
thing, if you don't like your medial lateral, so you see your canted medial lateral, so you could reverse what you just did. You could pull back. You could unlock the delivery system and pull the pusher all the way back into the right atrium. So you've allowed the balloon catheter more flex, and then what you would be able to do is push it up against the lateral aspect of the valve. So
Yeah.
it depends what you like.
Yeah,
I think
kinda
I like
this.
this right here, actually. Bob?
Yeah, looks good.
All right. Let's bring the lungs down and let's pace.
Lungs are down.
And now we're just going to watch and make sure our pacing is reliable.
All right.
Uh-huh.
At 140.
Yeah,
Go
I like
ahead.
it.
Oriented.
Yeah,
Like it?
A little bit.
Yeah,
Go in a little bit.
Go in a little. It's good.
Often adjustments at this stage as opposed to in aortic TAVR. That looks like a perfect position.
And can you stop pacing and bring the lungs up? Deflate the balloon. All right.
So what do you think about how we moved it during the deployment?
Yeah. Okay, careful, 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 pacer.
Oh,
There we go.
Yeah.
Nice.
That looks beautiful. You guys made it too easy.
Yeah.
There you go.
All right, let's stop right there for a minute. Bob Burke, you are up. Can we slow
All
that
right.
heart
Well, we
rate?
still have lots of
Well, we got
MR,
a
which
wire
goes along
across
with
it.
the wire across. That's typical.
Why don't we get this out and put a pig across it?
Yep.
Again, aortic valve
I
looks
got
like
all
it's
the flex
opening
off.
completely normally, which is the biggest thing that we're concerned with, making sure that we've not caused any issues with obstruction acutely. So that's looking great. And specifically what we're looking at is here. And you can see on that right pane how well the aortic valve is opening, and that looks great. Again, not seeing any flow acceleration through the LVOT. Again, that's a good surrogate for any obstruction right there. She has a little bit of AI, but again, nothing exciting. We're still paced rapidly right now.
Can you bring that pacemaker right down?
So the pacemaker is disconnected.
Okay, so that's her.
That might be her pacemaker or her.
Hey, Dave and Herms, do
Yeah.
you guys ever routinely post-dilate these mitral valves or add a little bit more in the balloon and give it one more squeeze before you leave?
I've done the latter. I routinely post-dilate. No.
No.
What about you, Herm?
Same. Don't routinely.
What about you, Jack? You brought it up for reasons, so.
Well, I think there's a couple of ways to do this. One is to look at the shape of the TAVR valve inside the surgical valve and see if you've gotten as much out of it as you can. The other thought is to just routinely post-dilate. Adam talked about that a little bit. Megan, what do you do?
Yeah, I think it depends a lot on your
pressure.
residual gradient and how the valve looks. I did just want to say, because we have so many fellows in the room, if we did have LV outflow tract obstruction at this time, Srini, maybe you could talk a little bit about how you observe that right away. Do you put a pigtail in the LV? And what are the medications and treatments you would do immediately?
Right, exactly. I mean, I think that we just, as previously mentioned, if there is LVOT obstruction, it's, we're in a real trouble. We're in a real trouble area.
Let's shock
So
him out of this.
obviously the
Let's shock
pigtail
him
in
out of
the
this.
LV, obviously at that point,
Someone on
angiogram
there?
going forward,
Jamaica?
but it could turn into a surgical emergency at that
Okay.
point. Additionally, I
Charge
will
it up.
mention the
Are you
pacing.
staying?
Are you still pacing right now, Dave?
No, we got VT. And let her rip. Yep.
Okay.
Hey, Kendra,
Much better.
This is what
any
happened when we
tricks
put the
for
wire in
treatment of
just to start.
LVOT obstruction at this point in time?
So there's no LVOT
Pressure's
obstruction. I actually just
142.
went
What's our
through
LV
and
pressure?
did a CW through the LVOT. And this is what we had. So our gradient,
172.
peak velocity is around 2 meters per second, maybe a little bit less than that. So there was no evidence of obstruction and does not have that classic obstructive morphology to it.
You know what
Now
we're going
still
to do right now?
transgastric.
Patient is really nice and stable. I'm happy we want to do some hemodynamic measurements. Let's throw to Doshi and Sharma and let them do their case. What do you think of that?
Yeah, and I'll just say right now, just the LV radial A line, the delta is 10 millimeters. So I think we're in good shape.
Okay, why don't we throw to them and we'll do some measurements and we'll come back. Does that sound good?
Yep, great. Outstanding.
So
Bonita, I
Steve,
have a
to
quick
answer your
question.
question, we have done rescue procedures, both lampoons and sesames, in these situations. Otherwise, it becomes a surgical emergency.
Great, thank you. Raul and Alok, we're back with you.
Wonderful.
I didn't get to introduce the rest of your panel, but we do have Sri Iyengar and I have Didi Wang is here and Kendra Grubb is here, and we've added Adam Greenbaum.
That's great.
Great.
Thanks for being here, and welcome again. Since we don't know exactly
And
how much
Bonita
time.
Shah, sorry.
Yes, of course. Since we don't know exactly how much time we'll have, we'll just go ahead and get started here. Let me, if I can get my slides up for the case presentation, and we can go to the next slide. This is my introductory and closing slide for every appendage case, and so obviously nothing so exciting about the left atrial appendage in an occlusion case, except for the fact that the left atrial appendage is dangerous. And so just go one forward. It has been called literally the most lethal structure that exists in the human body, because if you do the math as far as the likelihood of having a stroke because of that little thing that we don't, not sure why we need it, it's very significant. So hence the reason for this case. Let's go to the next slide. Okay, so nothing so dramatic. This is a 69-year-old guy with actually a history of persistent long-standing atrial fibrillation, progressive shortness of breath, and increased heart failure symptoms. And we actually did a catheter ablation for long-standing persistent atrial fibrillation and he was an extensive ablation, wide area circumferential ablation for the veins, mitral valve isthmus, posterior box essentially completely isolating the posterior wall, and actually left atrial appendage electrical isolation. So that's critical in this particular case, as we'll get to. And the patient has had a single chamber, essentially an AAI pacemaker for sinus node dysfunction. Hypertension, dyslipidemia, and obstructive sleep apnea. Next slide. He's been chronically on apixaban, metoprolol, Crestor, and Tylenol PRN. Next slide. You notice he's not on antiarrhythmic therapy. And of course, I have to show the fact that he's maintaining sinus rhythm after an extensive catheter ablation. Next slide. So he's paced, but no atrial fibrillation episodes. He has a CHADS VASC of 3, hypertension, age greater than 65, and heart failure. Has a HAS-BLED score only of 2, and we're going to talk about that to follow. Next slide. So we'll go ahead. Perfect. So we're going to go ahead and go to what we've done so far. So we've already performed a transeptal puncture. We've actually already delivered the Watchman dual curve delivery sheath and a pig in the pigtail catheter in the left atrial appendage. And we've actually put up an ICE catheter. Now, you can see from the screen, if you can see the right-hand panel, we have the TE images. So he's already been Bob Burked, right? And so those kind of beautiful pictures, that's the Bob Burke sign. But Dr. Sharma has become an expert in 4D ICE. And what we thought we'd do with this case is actually compare and contrast the use of 4D ICE in transesophageal echocardiography. So Alok, you want to take it away?
Oh, perfect. May I have my slides, please? So I think I'm just going to start with the usual intra-procedural workflow for ICE-guided procedures. Most of the time, we do this in the cath lab under conscious sedation or local anesthesia. It is a single operator, but I think when we are starting, you can have 2 operators. And typically, it's better to do this from the left atrium. And what we're going to show today is the Siemens AccuNav 4D ICE catheter, which is a 12 French catheter, but has a field of view which is 90 by 50. And actually, we're going to show you the newer generation, which is a modification of the previous catheter. And the imaging element to the tip is even shorter now. It is a 10 millimeter shorter. Next slide, please. So usually we do a 14 French sheath for this ICE catheter. You can do it on the same side or the contralateral side. Next, please. We start with the home view. I mean, everybody knows that. Look at the tricuspid valve. Next, please. And the first thing you do is look for pericardial effusion. You anteriorly flex the ICE catheter into the right ventricle and then just do a clockwise rotation from the RV to the LV, and you can look for baseline pericardial effusion. Next, please. I mean, you can look at thrombus from the right-sided views. Basically, it's a far-field view, so the imaging is not that good. You can look at the basal part of the left atrial appendage from the right atrium and the transeptal view. And from the RVOT view, you can look at the longitudinal part of the left atrial appendage. Next, please. The transeptal puncture is performed with 2D guidance. I mean, you really don't need 4D unless you have another device in place and you want to just avoid that. Next, please. And then you can follow the procedural steps. Go to the next slide. And I think this is the key slide, because how to do the single transeptal puncture. So you basically do your transeptal puncture wherever mid or inferior posterior, depending on the anatomy, and you dilate the septum with the delivery sheath, and then pull the delivery sheath back, and then flex your ICE catheter and just follow the wire which is left into the left atrium. Next, please. And then there are 2 typical views you can do. You can do either retroflex left atrial view, where you posteriorly flex your ICE catheter into the left atrium and look at the appendage, or you can just rotate it and look at the appendage from just above the mitral valve, what we call the supramitral view. Go to the next one. And if you do the retroflex left atrial view, this is the first imaging you will see. You'll see the circumflex in the mitral valve and the left atrial appendage. And if you counterclockwise, you'll see the aortic valve in place. And then you can do your imaging from there. The good thing about this catheter is that you can just park your ICE catheter at one location in the left atrium and just image. And so you just can park and image for the entire case. Next, please. And this is how the supramitral view looks like. You look at the posterior wall of the atrium and then the longitudinal view of the atrial appendage. Next. And then you can do your measurements. You can do your 3D MPR that will give you a coronal and en-face view, and you can compare that with your CT scan. So in my practice, I usually do a pre-procedure CT scan, so you can plan your procedure. I think for this case, for logistical reasons, we could not have the CT as a pre-procedure, so we did the baseline TE, and we wanted to compare that. Next, please. And then you can just do your measurements. Next one. Next, please, you can follow the device delivery. Next. And then you can do your measurements in the 360 degree in the same view what you have parked your ice catheter, and do your compressions and compare that with angio. Next one. And then you can do your leak assessment in the MPR view or the 2D. So I think I'm going to go hand it to you, Rahul, and see what we have done, and if we can replicate the ICE imaging today. I think that's the goal. So.
Absolutely. So that's great. And then actually, while we're doing that, it'd be interesting, I'd be interested to hear from the panel, and actually from your opinion, Alok. You know, the old days, we used to think about trying to avoid having two things in the left atrium, whether it was for ablation and looking for the appendage for thrombus, obviously not wanting to cross first. So we would put the catheter, and this is of course old ICE, we would put it in multiple places to try to visualize the appendage, whether it's in the coronary sinus looking up and basically getting that supramitral view, going into the left pulmonary artery, but obviously not the same kind of views as getting direct visualization in the left atrium. And so I don't know if the panel has any comments or experience. Now with current technology, we might want to revisit that, right? Because the images and the machine quality is just so much better. In the meantime, what we've done so far is, so as I mentioned, we have a sheath in the left atrial appendage. We have a pigtail currently.
Oh, excuse me. Do you want to go over the baseline TEE?
Let's go through if we can actually show then, you know what, if we can display again the TE images, Sunny,
so
thank you.
So that the audience has a baseline imaging
Absolutely.
what we are dealing with.
We had mentioned that the patient, in this case, as you can still see on the fluoro images, the TE probe is still in. Dr. Burke did a full TE assessment on the patient. The patient has no thrombus, and you can see essentially the interesting shape of this appendage, which what we have neglected to tell you is that the patient does have a history of having a CT prior to his catheter ablation, and he had a very large ostium. And now you can see the measurements here are much, much less. So look, you want to go through these and compare?
So you can see, go back to the previous image, please. So you can see in the 45 and 135 degree views that there's an anterior lobe, but also the trabeculation start right and go posteriorly, and there's another lobe over there. The measurements are, I don't have my glasses, but 1.6 to maybe 1.8 centimeters, so 16 to 18 millimeters in the largest dimensions. We have adequate depth into that lobe going in. And go to the next one, please.
Hey, Alok, can I get a couple of comments from the panel on the
yes,
comparison of this? I'm going to ask Didi Wang first, and Megan Corwright to comment on the comparison between the CT image ahead of time, the ICE image, and the TEE. You know, what I see right now is that you may have a slight difference in sizing depending upon the device you're using, and that superior rim or superior sulcus is way better seen on your TE than your ICE image. Didi, what do you think of these different modalities for sizing and imaging?
You know, that's a great question. It all comes back to hospital resources. You know, I can bring it to Srini and Bonita to see what you guys have available at your health systems. But for us, we're a pro CT site because we're a heavy TAVR user. So we know that the appendage is not a circle and that it could be ellipsoid in shape, if not amorphous. And we don't really do any more pre-procedural TEEs. Obviously, we completely stopped in the pandemic because we didn't have enough PPE. So everybody's really shifting to CT now, just like we do for TAVRs. Now, ICE is a new technology. There is limited scalability for it right now because there's a supply chain demand mismatch. There's not enough ICE catheters for all hospitals that want to use it, and the ICE technology is, again, not standardized, and the proficiency is not across the board, too. Then you come back to the question, who's holding the ICE probe? The person that held the TE probe or a fellow who's holding the ICE probe? And these are beautiful ICE images. They're very, very challenging to get. Those are incredibly pretty. TEE comes back, I guess TEE is what I'm familiar with, and I'll just say, I have to thank the American Society of Echo in a sarcastic way because an ICE catheter probe, I think, Srini, is like $1,800, right? But the cost of Burke and myself who hold a TE probe were $99. So until the ICE probe can match us, you'll be using us more.
You are underpaid and underappreciated. Interventional
I appreciate
echo,
the ASC.
no doubt.
I mean, Bonita, what are your resources that you have?
No, we largely rely on CT as well. Our operators who do the Watchman really rely on the CT more. Occasionally, the ICE will be pulled out, but you don't, like you mentioned, you don't always get a full view depending on the orientation and things like that. So we are very CT heavy here.
just want to play devil's advocate here too. We've done a number of CTs and on table TE, and we found significant valvular disease that wasn't seen prior to the CT because the patient was coming for a Watchman, not necessarily a valvular evaluation. And it does change the complexion on the table. Sometimes ethically you have to look at it and say, hey, there's severe MR plus this appendage issue. Do we need to take them off and discuss this? Maybe a surgical approach. I mean, this literally has happened. I will say that, again, in all things being equal, I do like having another physician in the room performing a TE, having another pair of eyes on the patient. So I am a pro echo TE person, but I also realize, timing, facility, ability to pay for things, as well as physicians having, workflow. If you have another physician in the room, it does take extra bodies and extra time. So I think this is going to be a very debatable topic going forward.
No, I agree, and I think the reason I moved to just ICE and CT in my practice was because I just could not get anesthesia to schedule these cases and another echo person because it was very difficult to schedule these, and now you can just do it with pre-procedure CT and with ICE under conscious sedation. Now coming to the cost, and I think if you can eliminate the personal cost with the anesthesia and also another echo person, there has been studies done with 2D ICE catheter that it's actually the cost neutral. It's not that much difference. So I think in the interest of time, what we're going to show you is, can you go over the fluoro images?
Yes, indeed. So we have actually on the fluoro save image, you can see an angiogram of the appendage, and you can actually, if I come on a fluoro, you can see where my sheath is and the pigtail in relation to that.
Just go over I think from the starting when we did the transeptal, and we can do show the ICE images for we did the entire case with ICE guidance, and can you show the interatrial septum, please, on the ICE?
So as we're scrolling through those images, so again, as Alok mentioned, the workflow, obviously, we have 2 sheaths in the right femoral vein, including the larger, longer sheath for the ICE catheter. We put the ICE catheter up. We did a transeptal with a standard SO1 sheath. We then exchanged the SO1 for the Watchman dual curve delivery sheath, and then pulled the sheath back after crossing, and then crossed with the ICE catheter from the hole that we created, which we can actually, I think we have those images coming through right now. Yep.
Yeah, and I think you can see that.
Right there, right? So we have obviously sheath.
And if you can show the transeptal puncture on the ICE, please. So you can see the septum actually is pretty thin. You want to comment on that, Doshi, because of
Absolutely.
Of
so this patient's had a prior ablation and a prior transeptal, and so often you see fibrosis just as a result of having been there before, right? So there was a little bit of oomph in doing the transeptal, and obviously you can use other technologies such as RF needles or whatnot.
Go to the next ICE image, please. Go to the next one. Again, we're just looking at the septum to see where to stick it. Next one. And then once on the fluoro, we'll demonstrate that once we dilated the septum, we just...
yeah, you can see it across
we just pulled back. We just advanced it next to the wire as a landmark, and for some reason the full fluoro is not... there it is, into the left atrium, and it was just the first attempt. And then what we did was we retroflexed the catheter, advanced the ICE sheath, and then that's where we are right now.
Right.
And that's the imaging of your appendage.
And this technique, obviously, we've used for a long time when we used to do double transeptals for all AFib ablations, or even use alternative technologies like the robotic sheath or whatnot.
And we're going to show the baseline measurements on the ICE. Soren,
let's show that real quick.
Yeah, and then we'll deploy the device.
In the meantime, actually, we can start actually process of deploying them. So my sheath is in a stable position. Our pigtail has been in, and one thing I'll mention for the fellows, I have not let go of my delivery sheath this entire time. You maintain a little bit of counterclockwise torque, having the sheath orient anteriorly, right? And you hold that, and you don't let go, because you don't want it to drift back and direct your device posteriorly. All right, so if we're ready to deploy, actually, so we can hold respirations.
Go to the baseline measurements, please.
Okay, and we're going to come back on the pig, and I'm just obviously holding my torque on my delivery sheath. We've got good backflow of blood. We've got flow going through the device. It has already been prepped.
You've got beautiful coaxiality with your flex ball on the imaging that you have there. can you comment to all of us in the audience what your decision-making process was for what sheath you used, anterior, double, single?
You know, honestly, I will tell you that it is very unusual that I use anything but a dual curve sheath. It's less critical, obviously, now with Flex. For the anterior chicken wing, then sure, I might use an anterior curve.
So I think this is a newer sheath. What they just told me this morning is an FXD Flex sheath, which is 14.8 French, a little stiffer than the double curved sheath. It's a hybrid between anterior and double curved, but a little bit bigger. So it's a new version of this sheath.
So here we'll go a little slow for fun. So our flex ball is out, and you can see I'm oriented toward the anterior side, and then it's going to come back slowly on the
There's
sheath.
just a little bit of tenting there at the
Yep,
left atrial
that's
appendage.
exactly
and
right.
That's where we're doing just left to right, nothing forward. That flex ball you can advance.
Well,
but
and in fact, in this particular case, one thing I don't know if you guys saw on the TE images, and we can go ahead and breathe. And I'm going to go ahead and push in a little bit to try to envelop, and we'll wait a second and let the device warm up. Okay, so there was actually, you can appreciate on some of the images, there was a significant pectinate that we were concerned that it might constrain the device. So that's issue number one. Issue number two is obviously you push too much, you're going to go into that chicken wing, which you really don't want, or go posteriorly. But I think, let's see the images that Alok can give us with ice.
one of the things that has changed with Watchman Flex, with that soft flex ball that you can release in the mid appendage and then advance.
That's exactly
When we're doing
right.
ice-guided patients now, my patients are awake, so they're chatting the whole time I'm deploying. That's a time I say, now we're just going to hold our talk, but we don't have to worry about deep breaths. I don't want them snoring. I want them to be awake during that time. Oftentimes they're watching just like a PCI. And so I think that we can do this procedure very safely without having them unconscious, which for me, the transition to ice-guided LAA was really based a lot on patient preference.
Megan, for your septal punctures, do they have any, how sedated are the patients, or how do they feel, how do they respond to that?
I have not had patients feel the transeptal puncture. I do use a Baylis, so I can't say I've had a lot of patients awake when I've been using, traditional SL1 with the needle, because I use it so rarely now.
Yeah, we've obviously done for left-sided pathways or left-sided catheter ablations under conscious sedation. I've done transeptal for years. Patients don't feel the transeptal puncture.
So Soren, go live. So you can see, I think we wish we could have done this with live ice as well, even though it was live, it was frozen. So you can see the Watchman device landing really nicely next to the circumflex and the mitral valve there on the imaging. But I think let's go to the basic imaging first at the measurements we took, and then we'll do the measurements after post-procedure and then compare it to the basic measurements with TEE.
We can't, it'd be nice if the X-ray image was a little higher magnification. Your technique for deployment was outstanding. We love that you were in that more of the anterior lobe. It looks, do you have any comments about the shape of the device? Are you happy with it? Do you think you'll have enough compression? And tell me what you see on that angiographic image, because a lot of times I'm not totally sure what that contrast injection is useful for.
It's really assessing for peri-device leaks, right? So obviously contrast will go through the fabric of the device. And so it's actually, you don't want to inject with the sheath so close to the device, and you don't want to inject very forcefully, actually, because it can cause misleading and you think there's potentially a leak. So you really want to see if there's early flow around the device, not anything going through the mid portion. As far as the shape of the device, I think that's actually the really important comment, and specifically now with Flex, right? So we've got obviously limited real estate for this trajectory in deploying a device, right? And so sometimes you'll get this sort of marshmallow shape. And so if you notice when I deployed, right after deployment, we pushed in on the device to try to basically, as you sort of involute the device, you're actually then engaging those distal anchors. And then you come back after the device is essentially warmed up. And I think actually in terms of the level of the deployment, we're right where we want to be. We don't have a shoulder. We can see that both on ice and on angio. And I don't think there's any dye going around the device that I can see easily, though I completely agree. It's not the best way to assess this. The best way is with echo. I'll do a tug under fluoro so you guys can see it. So that's pretty good.
You want me to
So,
inject?
so while this is going on, Alok, is somebody doing the measurements for compression on the MPRs, or do you have Bob Burke doing them on his T image? How are you doing it?
Yeah, so I think what we can do is we can show you the ICE images in a second here, the baseline measurements there. So you can see, so this was procedure guidance. You can see the sheet there and the pigtail catheter in there. So this was our baseline measurements. What we got was about 1.5 to 1.75. So on the TEE, it was about 1.6 to 1.8, which was pretty close. And you can see our pigtail catheter in the center. Go to the next one. Go to the next imaging, please. And our next imaging. And now we can do our baseline MPR. So to answer your question, I think we have Soren here who's from Siemens, who is helping us with the measurements. And but you can have your imaging echo person help you with that, or you know the device companies can the clinical rep can help with that too. So that's what Soren is an expert, and then he's going to do the measurements for us here.
Great. I have a question for Megan. Megan is on the east end of this panel. We are ICE advocates, contrast to all the other people on the panel who are totally wrong. So, Megan, there's a bunch of different catheters out there. Which ones do you like?
First of all, none of them are available prime time. They're limited release. So I'm using the 8 French AccuNav 2D ICE catheter for all of my Watchmans. I do pre-procedure planning primarily with TE or CT beforehand. In that context, 2D ICE is used just to help us understand where we are in the heart. The compression measurements, I think, the image that he's showing right there is not very different from what we get with the 2D. And it's really the shape of the flex that helps you understand the compression. We also do fluoroscopic measurements. I have to say, I'm a real world person. I work in a large public county hospital, just cross-trained all my cardiac surgery techs. They love ICE. They do all of the measurements for me. We've trained them up on that. So my vision for the future of Watchman is that this is like a PCI. People come in, I bring the ICE catheter into the PA, I look directly at the left atrial appendage, no clot, we proceed with sizing. There's so much overlap in sizes, we don't have to geek out about which size. There's just a lot of flexibility in that. And then they're awake during the procedure and we send them home the same day. Now I know Benita Shah on the panel does refer people for Watchman, and I'm wondering about when she's thinking about case selection, does she think that it's important that patients have the option for people to be awake and go home same day or be under GATE? Is that something that has resonated with patients when you're talking about their willingness to think about the therapy?
Do you have full your sheet?
Yeah, I mean, I think there's 2 points here. For my patients, it's more, you're thinking about the comorbidity. So I want to go back to what Srini brought up earlier. It's so important to discuss these patients as a whole, because sometimes what they're referred for and what they actually need are 2 different things. And so we review all of these cases in our larger heart team meetings, and some of them go real quickly because it's exactly what they were referred for and what they're going for, and we our usual plans of either MAC versus general anesthesia. But others are more complicated, and they really need to be discussed. Their comorbidities, their preferences. If they have severe lung disease, you may want to do this more.
That's great.
Under conscious sedation.
So we're being told that we've got a couple minutes. I just wanted to, before we release, let's go ahead and what measurements do we have so far?
Are you able to show us comparative images between the TE and the ICE so that the audience can decide what they'd like to look at? And maybe Dee Dee will comment on that.
Sorry for 1 second. Christy, I didn't hear you on the measurements.
Oh, I'm sorry. We have a 20.7 on a 24 millimeter device, which puts us at 13.8% compression.
Yeah, I think we need to call Bob Burke to
right.
do
Obviously,
the
to get our comparison for compression, we would need Bob, of course, to do that. We have the TE in place, and we probably would do that in the interest of time. Then, Does the audience or the panel have any comments? That's wonderful.
No, it's a great demonstration of ICE for LAA. One of the things that we just want to think about is, ICE is already here. It's not going to go away. So
Right.
CT and ICE is definitely the future. The question for Bonita and Srini would be, long term, you have the amulet, you have the flex and other LAA devices, but we do have a pass criteria for the flex, and we got to see comparative for PV device leak and everything. Which one would you be more comfortable using CT ICE for, and which one CT TEE?
So into
I think that is, again, I think it's a very debatable situation depending on your institution and who you're working with in your comfort level. I think, hearing Megan's points is amazing that, we can be fully solo operational almost to the fact that you don't need extra bodies, but I still feel biased in a lot of ways that, the extra pair of eyes, the fact that the T does pick up a lot more other things pre and post 45 days, I can agree, maybe just getting the CT. But I think this is going to be institutionally dependent. I don't think it's going to be one way or the highway. I think we're going to have some arguments about this going forward. But I will make another point about the going home the same day. I think that's another controversial point. Megan, what are you doing for the groin to get them home that same day? Are you per-closing, per-stringing? How are you getting them home?
I will say, for anyone at the meeting, I can talk about this all week, so pull me aside. But I think we're going to have to say goodbye to Rahul and Alok. That is a gorgeous result. Beautiful squeeze on the device, landed it right at the ostium. Just a round of applause for this live team.
Great.
And I know we want to go back over to David and Herms and see what their final result is, and then we're going to be getting ready for our break.
That's perfect.
Hey, guys. We're really pleased with where we're at. Patients real hemodynamically stable and whatnot. Bob Burke, you want to tell us what you're seeing?
So right now we're looking down on the face of the aortic valve, and Dr. Riley had asked me to look at this to make sure that the aortic valve was functioning normally. It opens beautifully right here. And actually, as we slice down into the aortic valve, you can actually go and see where it opens up and where the neo-LVOT is right through there. So we've got a nice opening. We're not having any issues there. We looked at this in a deep transgastric.
Go to echo, please. Go to echo. Thank you.
So we had a deep transgastric here immediately afterward. Just pull that. You can see it looks like there's a little bit of flow acceleration there, so there was a little bit of a concern. So what we did is we ended up getting a gradient on that, and the gradient was around 4. So this looks great. There's no flow acceleration of any hemodynamic significance. It was really more of a Doppler finding than anything else. As far as the mitral valve, it looks beautiful. We have a mean gradient here of less than 2 millimeter mercury, so that's pretty much physiologic. Nothing to worry about there. We swept through. We saw no evidence of any paravalvular leak. There was trivial central MR at first, and that's pretty much settled down at this point in time. Valve itself looks beautiful. It's opening up wonderfully. We did the dual view here. There's really no significant pinwheeling with this valve, so it looks great. Again, no issues with neo-LVOT. This turned out really as good as we could have possibly hoped.
Herms, you get the last word.
No, I think it was a great demonstration of both the pre-procedural thought process, did a septal ablation, and then I think procedurally we had some issues with rhythm, et cetera, got through that, and then...
I liked getting to have Adam walk us through a technique
yeah,
that
and then
we
we're
got
able
to
to
use.
demonstrate the right way to do it, and got a beautiful result. We just did a quick LV to the radial pressure. It was a less than 10 millimeter mercury difference, so I think great outcome here.
Dave, are you closing the septum?
No, it's all... Bob, I love the added surgical perspective on the pre-procedure presentation. So, all right, I think there's a break now or something, so we'll see you guys when we get back over there, okay?
Nicely done. We'll see everyone back in 25 minutes.